Welcome to another episode of She's Well. Today my guest is Dr. Bidaya, and I should call rather Bidaya because we are friends. We might not be seeing each other very frequently, but whenever we see each other after years, we know where to pick up. And we find always connection. And it so happened that we always meet each other in some conference setting where Bidaya is speaking in something. And when I asked Bidaya that, send me your intro, she was so humble. She sent me consultant OBGYN, minimal invasive surgery specialist. And I was like, oh my God, it's too minimum. So she's a regular speaker into Endo Dubai. And Endo Dubai is a worldwide, is an event where people come from worldwide, from all over the countries, and, you know, amazing speaker. And it's something become the brand of Dubai.
Exactly. Yeah.
People know Dubai also for Endo Dubai. Welcome, Bidaya. How are you?
Thank you very much, Bushra. You know, we are really friends. It's like in the heart.
Exactly.
Thank you for this. And as they are telling, you know, as it is smaller, it represents you better. So I don't believe in putting many lines for introduction.
Yeah.
Thank you very much.
No, you're really amazing speaker, and it's all scientific. The forum you speak, they're very important. So authenticity, that matters a lot.
Thank you. Thank you. You are doing a very nice job. I like also to help in education and awareness of the patients, especially in this era of the time that we are having a lot of information coming to us from the internet, from the friend, and even from the doctors. And the patients, they are really, especially the women, they are very confused, and many times they unfortunately take the wrong decision. So this is really
especially
important.
in this era where revenue is a thing, which is hospitals maybe putting some pressures, or maybe doctors being motivated by revenue generation. So sometimes things are really not scientific, not very proper.
Sure.
So, you know, like I was discussing with you, our topic is think twice before you say yes to removing your uterus. And you were really interested in that. So then you were telling me about some presentation that you did.
Yeah. So actually, the nice thing about the topic that the concept of uterus, you know, women also think it's the womb. Okay. So since ages, I think women, they think that the uterus or the womb is the symbol of motherhood. They think it is the source of youth, of energy, of activity. And to be honest, I don't know why or from where this came, but if we look to cultural background and even religious background, this is what most of the women since ages continue to think about. Maybe little they don't think, but most of them, they think this.
Yeah.
And that's why it comes important. So when you remove the uterus, it's not like you are removing an appendix or something else. They don't ask you a question when they remove their gallbladder. Exactly. They don't do anything, but when it comes to the uterus. It becomes really a big
maybe
issue.
She feels it's the core of womanhood or the femininity.
Exactly. So the also important thing that to know that these feelings are really there. And this is what I was telling you once I did a presentation about the effect of removing the uterus. We call it hysterectomy, of course, in a young woman. And when we consider the young woman, it's the age below 40. It's considered young. And you can feel that the perception and the satisfaction from the woman is different than the woman above 40. Right. And when I investigate in this, you find that it is really present, and people, they do also studies and articles, a lot of articles about it coming from China, from Japan, even from the US. We consider it's like the modern world. But women, whenever they also act the same. Yeah. So I found that there is a major effect on the body image, the woman's self-esteem, she will tend to have depression, the way that she is dealing with the partner, with the family, the sexual life, all of these things are present. Everything, and of course they have also factors that will lead to this. And one of them that you will talk about is the importance of the patient to consent her decision. This is one of the most important factors that it found. If the patient was not having the enough counseling, explanation, alternative, discussion of alternative, and what is expectant from her after the management. If this is not discussed with the patient, she will tend to have all of these problems after the hysterectomy. And I'm happy that you will focus on this. It's really important.
Yeah, exactly. And especially when we offer, right, hysterectomy, mostly around 40 years of age, that is the time that which is important also for family. I mean, children might be preparing for university, so she's needed at home and she wants to be there for her family, for her children, their foundation making years, and then being away from the family. And that effect also goes to the family, because those were the important times when they needed mom to be there to support them. And very rightly said that it should not be a sudden decision. There has to be a time. They should be given some time to think, to see the alternatives, and then they can have multiple opinions and decide that what they exactly want, rather than just ending up in hysterectomy. So what I thought that we will just take some cases, and with that cases we will just go on. So most frequently happening thing, the endometrial polyp.
Yeah.
So I have a case, Hajra. Hajra was around 40, and then she was having bleeding problems. She went to the hospital. In the hospital, they did scan for her, and they found endometrial polyp. And doctor counseled that it is a recipe of malignancy or something like that, and she needed hysterectomy. And patient tells that doctor didn't take long. It was just a scan, and the scan came, and she was offered hysterectomy. But in her core, she wasn't satisfied, and she wanted to check alternatives. So she came to us for the second opinion. We did hysteroscopic polypectomy.
Excellent.
And in the polypectomy, it came the benign polyp. And at the same time, she was 40 years old. We told her that we can keep Mirena as a prevention from the polyps. And she agreed. And we kept the Mirena, and she doesn't have any complaints of irregular bleeding. We have been checking her whenever she gets the scan done in the clinic. It's all normal. So, but she was surprised that how she was saved from such a big decision. And that was the time when her family was also going through something, and she was needed there. And she's really thankful for that she avoided the hysterectomy.
Yeah. Actually, this is a very nice example, Bushra. And, I am a surgeon. So
we all love surgery.
The surgeries are my life, and this is the way, it's my work. But still, I will not say that hysterectomy or removal of the uterus is a wrong decision, rather than not the best decision, because I don't think that doctors, they will remove a hysterectomy is completely not indicated. I'm not sure if it's there, but this is the way that we know ethics in medicine. I believe that it's not the best option. So whatever the diagnosis is, if you want to have an option to put it for a patient, you need to tailor it, as we say, as you are a tailor. So you tailor the management that you have, the option that you have, to the patient. This is the job of the doctor.
Right.
And this is what, when the patient comes to me, I check, first of all, her support system. Like, she has a family, she has kids, she has responsibility, she is a housewife, she's working. She, as you said, if her kids will go to the college, she has a lot of stress. This you need to analyze, her socioeconomic status. You will see this part. And then you will check what is the patient, as always we are telling. And even I put it in my note, patient perspective. You ask her, what is the thing that you are worried about? If she said, I am worried about cancer, okay, then you will guide the management. If she said, I'm worried about the bleeding only, you will understand how she is telling you, the patient perspective. After you see this, then you go to the diagnosis, and you have the diagnosis, then you will tailor the option. You say, look, you have 1, 2, 3 options, and the way you are offering the options to the patient, also it is a skill. Because if somebody said hysterectomy for polyp at 42, she's 40. Then you will say, it is not wrong, but it's not the first. So you will not start with that one. Yeah. I believe polyp is really important. You can't say keep the polyp and go. What you did is really perfectly, I think, the most suitable management plan done for such patient. You offer them the see and treat option. You see and treat, which is the hysteroscopy.
Yeah.
You see the situation, you see the polyp, you see around it the endometrium, and you remove the polyp for what we call the analysis, the histopathology, and also you check the rest of the uterus, so you are sure about the rest of the thing. And then if the result came benign, then you tell her this is treated if she had another problem, as you said, with Mirena. So I think this is perfectly
but
well.
at least all the options should be on table.
Exactly.
And then she should, what we call informed choice. She should know in and out of all the options, and she should have a choice that what she want to choose. And she knows herself, so she will choose the option which suits her the best.
Exactly.
So it cannot be that doctor with the air of confidence straight over one option.
That's well
Hysterectomy, that's too far.
Yeah.
That's too drastic. Yeah. So now I will tell you another patient that is also one of the very common scenarios with us. She was a teacher in a very good university, and she came to me and she said, while giving lectures, she's facing heavy periods, and she said it's almost impossible to go on with the classes and thing, and even with insurance has a problem. So she said, let me enter the emergency, and whatever not approving, or let it be fast. So we admitted her through the emergency. We did the hysteroscopy, and it is therapeutic also when we do the hysteroscopy. So her bleeding just calmed down while we were doing hysteroscopy. After that, her bleeding was quite settled. Histopathology came and it showed hyperplasia, endometrial hyperplasia without atypia. So I counseled her that she's a very educated lady, teaching in university. And I gave her option that you can have Mirena, you can have, but with the Mirena, you'll be having compliance with the histopathology, coming to the clinic every 6 months, and I'll be doing your histopathology or something, a small DNC kind of procedure, which we call PEPEL in the clinic, and we'll be checking whether you're regressing or you're not. So she agreed to that, like she just did the Mirena, and I gave her option of hysterectomy also, that there is a final definitive endpoint of the treatment where you don't need to follow up and it will be done. It is a uterus removal. She was very educated lady, and she said, I'll be real compliant with the follow-up. I don't have problem. Go for the Mirena. And for her career also, that was her probably probationary period. She was establishing herself in a good career. So we did Mirena, and every time her histopathology came very perfect. Now she's been off follow-up, and like she's very happy. And she told me, even though she was very busy, and she said, I'm really, really happy that it's been done nicely.
It's amazing. Actually, this is very important that you mentioned. Hyperplasia is one of the really the most common worrying result for the woman. And you mentioned that it was without atypia. I think for the women also, this is the way we told them abnormal cells. So if you have abnormal cells in your uterus, you should know that there are different types. It starts with the very, most of all, very nicely acting cells. That the percentage to go to cancer, what every woman is afraid, is considered negative. And then you get the more complex cells that it will be with atypia or complex. It will go more to have some percentage, and we will take it more in concern. So this is the thing. If you have endometrial hyperplasia, again, you look to the age. If you have endometrial hyperplasia in a patient or in a woman with her 50s, before the postmenopause, maybe you will tell her about the option that to be more aggressive. But when this age, I think offering hysterectomy is like super eradicant. It's like
exactly. It's too drastic. And then they can just go step by step. For our audience, we will tell hyperplasia means increased number of cells. And when those increased number of cells are same like the parent cell, we call it without atypia. And when they are similar like not similar like their parent cells, we call them with atypia.
And also, Bushra, also important thing, because you reminded me, the woman should not think that if she did not choose the surgical option, this means that she is taking a low-class option. No. Sometimes they say this is the best. No. Even with hyperplasia, if you have hysterectomy and also treatment with Mirena, it's a curative. You say the results came complete normal.
Right.
So it does not mean that they are less beneficial. No. And also for the hyperplasia, it's important in one of your management also to check why she has the hyperplasia in such 38 years. Maybe she's having polycystic ovary. Maybe she has increasing body mass index.
Diabetes.
Diabetes, family history. She also should know that she has a risk factors. Also, she can work them. Even if she had the risk factor and she removed the uterus, but the risk factor is still there.
It's still there.
Still, yeah.
And it could be journey also, like going step by step. Maybe it will ultimately end up in hysterectomy, but then she knows that she tried all the options and this is the only option remaining for her if it's not been curative. Also, without atypia, hyperplasia is only less than 4% leading to cancer.
Yes,
But
exactly.
with atypia is most of the time the hysterectomy is a better option because progression is 25%. And most of the time we get without atypia.
Exactly.
So
Correct.
most of the time, Mirena is the best option.
So the timeline that you give to the patient is really essential and part
monthly,
of
yeah.
the treatment. You tell her, I do this, and then I do this, and then I do this. And then if this happened, you go this. If this did not happen, you go this. So you will do like a pathway for her. We call it the
Exactly.
timeline management.
Yeah.
This is a...
And she was educated to understand actually in nowadays the women quite educated and they understand their plan. They are compliant, they're ready to follow up.
Yeah.
And then why not? They should be given all options and they choose what suits them, what suits with their life. And I have some patients like that also, that I am working in a job with a very good insurance. This is my last year of the job.
I want to take
So I
advantage.
want to finish it
I
off.
had a patient like this yesterday.
Exactly, yeah.
She said the same. She's having, maybe you will discuss it. She has CIN1. It's
Yeah.
like a cervical
Yeah.
problem. And she told me, I have 1 month remaining. And she's working in Emirates flight and their insurance is amazing. And she told me, I want this because the insurance is covering. Imagine, it's
Yeah.
correct. Some women, they think like this.
So they have to have the option,
Yeah.
what suits best for them. And my patient also, she was traveling back to country.
Then
So
she
she
went.
said, I will finish it off here because the best health system, I have the best insurance. So just finish it off. So we do go by patient and that is the best option.
Correct.
Now, these days, a very common condition people get is fibroid. Every third woman. So I was just thinking about having a specific example of the fibroid. But honestly, there's so many cases.
You can't.
So exactly. It was hard to decide which one of them. So we will talk the fibroid generally. Every third woman has fibroid. They're very frequent just because of this very sensitive, our ultrasound machine. The flip side is everybody get to know they have fibroid and they get just, anxious that what is it. So they're very common findings and they're just not in the muscle of the uterus. And but the management depends symptoms, size, and numbers.
And age.
And the
The
age,
fifth one.
and the
Yeah.
desires.
Yeah, it's very
Fertility
important.
desires.
Yeah. This is essential.
Yeah.
Yeah, and I hope that everybody is really discussing this with the patient because patient, the first thing she will tell you when she comes, she said, but doctor, my friend, she had fibroid, they did not do surgery for her. Or maybe she will tell you, my sister, she had a fibroid and they told her she can't get pregnant. It's like you have very different stories.
Exactly.
And why? Because you said in every third woman there is a fibroid. And fibroid, they are like from A to Z. You have different types, size, and the location is different. And even the age. Sometimes I have big fibroid, multiple, but in the age of 50. What you will do? She has no symptoms. And if it is everything is okay, you just follow up. Sometimes you have a fibroid for a lady that she is 22 and she's not willing for pregnancy and fertility now. The management is different. But the most important thing, because you are talking about removal of uterus, removal of uterus for fibroid, it's super rare.
Yeah.
Why? Because you will do it for patients that they are not fit for medical management, we say medical treatment.
Yeah.
They are not fit for surgery, or they did multiple surgery and they're caring, and they do it really for severe symptoms like heavy bleeding, pain, pressure symptoms, and at the same time they are not concerned about the fertility. So this group, it will become very small.
Yeah.
So that's why I believe for fibroid, hysterectomy is really, it
Too
should
drastic.
be, yeah, too drastic.
And they can
yeah.
sidestep from this.
Yeah.
Actually, let's extend the discussion here, because even the myomectomy sometimes is really unjustified, like less than
Yeah.
4 centimeters, small fibroid, and we see sometimes
Yeah.
being operated, patients are telling us, and then you feel, why on earth somebody just did operated?
Yeah.
So it has to be symptomatic at least. And then site, like what site is
Yeah.
there. And symptoms could be also the variety. If somebody, even with a small fibroid, not getting pregnant, maybe it is blocking their tubes.
The
After
location.
doing the evaluation, you will get to know which fibroid has to be removed. And they can be removed even by hysteroscopy
yeah.
if they're protruding inside the cavity
Correct.
and they're less than 4 centimeter. And they are causing symptoms, because we see frequently pregnancy with fibroids also.
Yeah.
That is also a very common
Yes.
thing. So many people, they're pregnant, they're fibroids in some corner of the uterus,
And everything
even in
goes
the main muscle, and enlarging along with the baby. So you have to see the symptoms. If no symptoms, even there could be many in numbers, but sub-centimeters,
Correct.
then we don't need to operate.
Yes, it's the same concept of tailoring. You tailor what is present to your patients. When you said you are surprised from women coming to you and they did surgery and you are really surprised. I remember a picture, because some patient, actually it was one patient, she brought a picture.
Yeah.
It's unfortunately we are not able to show the pictures,
Right.
but I think the picture is she came, she was very happy that she did a myomectomy 2 years back, and she said the doctor removed all the myoma that I have. Sure. And then she showed me the pictures. So they organized the myoma on the table of the OR. The myoma they removed, it was open myoma. And then I went to ask why not laparoscopy. He said because he can't remove everything in laparoscopy. This is the way. So he put like big, all arranged, big, small, medium, small, and pushed it to the size of maybe 0.2 centimeter,
Oh my
it's like the
God.
size of the pins,
Yeah.
and then more. And then, I was not able to tell her, but excuse me, what is the integrity of your uterus state, What is the
With
muscle
so much
removed?
scars.
So much scars and everything. With every myoma you remove also part of the muscle. So
Exactly.
if you want to keep this uterus for it to function well, to get kids, baby, and expand, what you left
And
for
there
the
would
uterus.
be many cuts on the uterus.
Yeah, it was really, and this is the same that you said. So surgery of myomectomy, it should be indicated, as you said, sometimes the size, sometimes the location, and also the way that you do it. This is either laparoscopy or you do hysteroscopy. It's also important. For example, someday, some of my patients also explain to them, I will put you in the OR, I will remove the myoma, but I will remove, and I show to her, if I have ultrasound or I have MRI, I will show to her, look, I will remove this and this, because this doing this and this doing this, but this I will not remove, like intramural
real.
deep. I say this I will not remove. It's small and will not affect any thing for you. It may grow later. It's okay.
Yeah, of course.
But
They can even return
exactly, but it will not justify that the risk. I will give you another scar on this sensitive organ, which is the uterus. So,
and what's the use of it if so many scars?
Yeah.
Like it can be very high risk for the rupture of the uterus also. So, and fibroids have other options also, like uterine artery embolizations and myomectomy.
radiofrequency also.
Radiofrequency.
There are also medical management, but it's not available in the area
So
here.
far.
Yeah, but they are outside, and I give some
But
of my patients.
they have a very high, like GnRH you're talking about.
but the oral GnRH.
Oral ones.
Now we have
but
oral
still they
GnRH.
can bring the menopausal symptoms also. So still patient has
Yes.
to weigh that
Exactly.
whether she has to be, is there any symptom, what her medication or treatment or surgery is justifying. Like if no symptom, what she's treating.
Yes.
Just the ultrasound finding should not be treated.
Yeah, if I do ultrasound, I'll find fibroid. If you do
Of course,
ultrasound, you will find
this is the reason
fibroid.
I don't do. So then another frequent condition, which I don't know nowadays, every other patient brings the ultrasound and there's adenomyosis.
It's very common, this one.
It's very common. So I was just thinking, whenever patient brings to me that she says, I have findings, doctor. And then I'm like, okay, fine. So adenomyosis.
But she will not check the Google before she will come. You know, she will be terrified with her face very yellow. She will tell you, doctor, I read about it. It's like, what is this?
Sometimes they read also. Actually, by the reading, I will tell you yesterday some patient came to me and she said, I'm HPV positive and if left untreated, it leads to AIDS. I said, wow.
Yeah, this is like a copy-paste.
Exactly.
This is the problem with Google, you know.
Yeah, exactly. And I was surprised with this conclusion.
Yeah.
And I was like, it's a virus.
Yes.
So one virus cannot lead to or give birth to another virus.
I like give birth.
It's something very new.
Yeah.
So this adenomyosis is actually endometrial tissue, the tissue which folds, builds, and breaks and bleeds every month from the uterus. Sometimes it enters and penetrates into the muscle for our audience knowledge. So this is very common when this tissue, it is in the muscle, it does what it does. It builds, breaks, and bleeds.
Correct.
But here, there is no exit for the bleed. So that brings the inflammatory reaction. So when a patient come to my clinic, I give them one example, that fibroid is like a ball between guitar chords. So if you remove the ball, guitar chords just come back as if there was nothing.
Correct.
And so surgery of the fibroid is also like that. You just remove the ball and guitar chords back to the position. But adenomyosis is more like coffee beans and rice grain mixed together.
Correct.
So when you just open and you try to remove, so if you consider coffee bean as the bad tissue, you will still take some of the rice grain, which is a good tissue, and you will still be leaving some of the coffee beans behind. So surgery is not perfect. So I always ask them, tell me,
what do
you have symptoms to justify that you have to come under knife? And honestly, most of the time, like they say,
because I saw, somebody told me in the scan or something.
Exactly. They're just, so will it worsen? Their next question is, if I don't remove, what future holds for me? Will it worsen? Will it become a malignancy or cancer? So you might be seeing these situations also very common.
Always. And Bushra, if we start from the first step, actually, the diagnosis should be correct. Because unfortunately, many, they will act on incorrect diagnosis. For example, the most common, she comes to you, she has previous 6 kids, vaginal delivery, and they did for her ultrasound, and they told her you have adenomyosis. The normal appearance of a uterus for a lady that she had 1 kid or 2 kids is totally different than a woman that she had already 6 kids. So, and when you look to this multiple times, it comes with the experience. When you look to this, you see this is a multiparous uterus, means that she get pregnant. They come to me, adenomyosis, I said, this is normal. You got 6 kids. Yeah. This is normal. So to start from the diagnosis, it should be really correct. And not only this, if the diagnosis of adenomyosis is there, and as you said, you don't have symptoms, this diagnosis has no relation. Stop.
Exactly.
Because this is, many times, it's a normal variation of the uterus, Yeah. The other thing is when the patient comes and she has the symptoms and she has the diagnosis. Now here, again, you will go with tailoring. You analyze the patient's symptoms and how much these symptoms affecting her. The menorrhagia, the pain, and difficulty in getting pregnant. You will analyze her symptoms and then you will offer the treatment accordingly. So usually I tell them, you put already very nice example of how women will understand the meaning of adenomyosis. Also for my patients, I tell them that it looks like, we all wash cartons, this yellow sponge. Used for washing the dishes and everything. And, it looks normal, same size, but when you squeeze it, all the water comes from the pores.
Right.
It's the same like adenomyosis in the uterus. It looks like, okay, the size maybe not that much big, but when the period it comes and the uterus will squeeze, all of this blood will go out, so you will have more pain, and you will have also the heavy period. And this is the symptoms usually explained. And that's why when you tell them somebody will do surgery to adenomyosis, so how you will do surgery to this yellow sponge? You don't know where is this place filled with water. And imagine if you cut this sponge here and then you say, okay, water, again more water, again more. So it ends up that the whole sponge is cutted. So doing a surgery for adenomyosis is really very specific and very specific to few cases. I'm always telling. Now it became like a trend. You see, many they start doing this. No, it's just very specific and needs skills. And really, really, you have a very detailed consenting with the patient and explanation. We had a patient even after all of this, and then we had to go, and then we did for her the partial adenomyectomy, what we called, and then she got pregnant, and then the uterus ruptured at 6 months. She lost the baby and she lost the uterus.
Yeah, then what's the use of it?
Exactly. So it can be done, but it's very specific, and it should be in a detailed counseling and also explanation of the patient what she will have. We are very lucky to have a lot of options for treatment adenomyosis in a very nice way. Hormones, and not necessarily women, they are
even
very afraid.
Pregnancy itself is therapeutic.
Perfect, it's therapeutic. And if you mention hormones, the woman, they will say, no. But you know, Mirena is like a miracle in the world, you know?
I really
It's just in the uterus, and you put it.
So many patients these days,
Yeah.
and it's protecting them from the hysterectomy. They can now sidestep from this drastic measure. So Mirena is really a miracle of modern science.
It's the first line treatment always, and you can leave her without symptoms. Nothing will happen. You just do follow up and see.
They say if you put it above 40, you can leave it till menopause.
Yes, correct.
So like all the things will be being corrected even before they happen.
Sometimes they will come to you, it's already 5 years finished, but she is 50 something. Okay, what's the problem?
Leave it,
Some they will tell, no, doctor, they told me it will cause infection, they will cause no, Mirena will not cause, it's okay. As long you are following it with your doctor every 6 to 8 months, no worries.
It will be all right.
Your examples are very nice.
I love
very
you
nice.
so much. So then is the chronic pelvic pain. So some of the patients also come and they tell that they went through hysterectomy for chronic pelvic pain. So I get surprised that one thing we do not have very...
And the pain resolved after they did the hysterectomy?
Yeah, that's another story. So, you know, the thing is, like, we need to have a dedicated clinics for the chronic pelvic pain if they conclude that they are doing hysterectomy for chronic pelvic pain. So the pelvis is this bone, and the uterus is not alone there.
Yeah.
There's so many organs.
In this bowel, you have a lot of things.
Bowel, and then this bladder, urinary bladder, and your poop passing tract, the ending there, nerves, muscles, bones.
Tendons. Yeah.
There's so much there. So I feel like when people do for chronic pelvic pain, it should be not an immediate decision. It has to be a journey. It has to be slowly excluding all, gradually excluding all the origins of the pain. It could be muscular, it could be neurological, or it could be from the bladder, it could be from the gut. And also sometimes all these diseases are actually finished already, but there's a pain memory. You know, like, because nerves have some mechanism of keeping the memory of the pain which happened in the past 6 months.
Unfortunately.
Exactly. So then there is no disease actually there. It's just the pain memory, and people just get the hysterectomy done.
Yeah.
And if it is originating from the endometriosis, which is the most common disease of the uterus and ovaries, there's something called hormonal trial.
Yeah.
So if they take hormonal trial and their pain is relieved or not relieved, so that also can be a decisive decision help that whether they need hysterectomy or not, or whether they need any drastic surgeries.
Yes. So you mentioned very nice way, you know, for the chronic pelvic pain, many women, they don't explain it well. We know that the definition of chronic pelvic pain, you should have this pain consistent, persistent, in a week more than 3, 4 times, at least 6 months. So some of them, they will come, she said, I feel always pain down in the last 2 months. So it's not. And I feel that the uterus, the womb, is the most innocent person in this story, to cause the chronic pelvic pain. It's very less. Even with endometriosis, it comes with the involvement of the peritoneum or the uterosacral ligament. Those are beside the uterus, are not exactly the uterus. I think, and I believe maybe you will also agree with me, because you are working also in private, so you will get patients in a different way, because they come to you, they want all the management happen on one set. I feel chronic pelvic pain should not be treated in the gynecology clinic. It should be in a complex clinic. So you gynecologist, you have physiotherapy, you have ortho, you have dietitian, you have the GI, all of them like a circle. And this is the way. But sometimes in private, maybe you don't have the access, but it is essential, because as you said, who will check that the bowel is okay? The GI doctor, the gastrointestinal, let's say. Who will check that you don't have intolerance to lactose or to sometimes of fruits? Who will check? The dietitian. Who will check, you said, the bones? Who will check the bladder, the uro? It's like all of them, they come together, and then I think you will see it also in the patient. You are surprised by the amount of improvement when you do it in this way. You do like a collaboration of treatment.
Exactly.
Physiotherapy. I feel
that's very important.
Yes, I like also physiotherapy. I do for myself, because after delivery work, all of these things, you need it. So physiotherapy is really one of the major parts to improve the chronic pelvic pain. And when we say chronic pelvic pain, you don't have major problem. Like you may have a patient that they have a fibroid for 10 centimeter, and she's complaining chronic pelvic pain, and she's just ignoring that fibroid. Also is different. So if you don't have major problem, you need to check all of this.
And it should be excluded. Only then, decision should be
taken.
Exactly. It shouldn't be drastic. It should be gradual.
Yeah, perfect. This is exactly correct. I think you are losing patient in your clinic.
I'm working in private.
But this is the best, actually. It comes on you. This is the way that you should do. This is the ethics.
Exactly.
And for every patient, you put yourself in her shoes.
Actually, patient satisfaction becomes the word of mouth.
Yes.
And I feel like one satisfied patient is worth anything. Like when they go back to their life, they're busy. Like I told you, this university professor, she's really busy in her career.
But at the same time, she's not ignoring her health. When you give them this option. She did the compliant and
then she got busy. But in her important time when she was into the new job and she was doing so good and she couldn't cope with the bleeding while lecturing to the student, it saved her just 1 day procedure, day case,
and she's happy.
1 Mirena, and she was really happy. So I'm really happy for her, and we can save a lot of women from the hysterectomy by doing such steps.
When you say about satisfaction, now I remember, sometimes, you will start learning from your patients, So I remember that 2 different sentences I hear from some of the patients, and it's really, it's like emotional for me. One woman, she will say, "Doctor, without the uterus, I felt like I am more like a woman."
Oh.
So you feel that really this removal of uterus, they give her power to trust herself, to work, and to get time for everyone in her community. So she feels more like a woman. And on the other side, you hear this sentence, which is like you can feel the effect of satisfaction. She will tell me, "Doctor, they removed what made me a woman."
Oh.
Look, this was
two different
perspectives, 2 different sentences, and you see that the uterus is the core of the sentence. And you see that I don't think that this woman will say this if she was really given the options and she chose that option and she had a timeline of treatment, a pathway of everything. She will not say this word. It felt like they. So I think this
You're right.
Really,
if she chooses, she knows what she's choosing.
Yes, exactly.
And whatever perspective she has, it will be part of management, and it should be there. Like we sometimes just give with an authority, we give the management that hysterectomy.
Yeah.
So I got a comment from somebody from my from a doctor, and they said to do hysterectomy you have to think hysterectomy. So probably I'm doing lesser of the hysterectomy because I'm thinking less, because the options are available.
Because
And
you're
it's-
doing right. The right
Exactly.
thing.
And they are choosing. So it's not that I completely let down. I give them option. And most of the patient, they choose not to have hysterectomy. They want to go step by step.
And even if it ends up with hysterectomy, she passed through this and she will come to
She
you
knows why.
convinced, and she's ready.
Exactly.
She knows that she did this, did not work. Okay, I know that this is my step. She's prepared, and she will have more satisfaction. And sometimes you say, if you do the hysterectomy for this patient, that she has the option to go for medical management. You did the hysterectomy now for this patient, and then you compare it for a patient that she passed through this and did not work with her, and then she's coming for hysterectomy. You did the same procedure. You are the same surgeon, the same technique for almost the same patient prototype, but you feel that this is not happy and this is happy.
Very happy.
So this is the satisfaction you mentioned. It's really essential. Yeah. I feel it should be always part of the counseling with the patient for all doctors, really.
Actually,
women are complex. It's not easy,
Exactly.
You will tell them, as I say,
Yeah.
you will go for, she will go for the general surgeon and said, your gallbladder has some stones, we need to remove. She said, okay. Though for cholecystectomy, removal of gallbladder, you have option if it's only stones, no thickening in the wall, not affecting, I don't know how many episodes per year or something is not happening. So you can't keep it. You do some diet, but they will not ask.
Yeah.
When
Oh,
come
they don't,
uterus, when come uterus, women know they are more precise in this.
And nowadays, women is really empowered. They want to know. They don't want surprises.
It's her body. Yeah.
Exactly. And this is, as a woman, we also would want to know what are the alternatives. Yeah.
Exactly. Correct.
We will not leave the CIN. We said somewhere the CIN. So CIN is a cervical cancer, not cancer. It's a neoplasia pre-cancer stage, which could be treated conservatively also.
Yeah.
And some people may choose, as you said, this person from the Emirates Airline.
Yes,
they wanted to final definitive endpoint of the treatment, no compliance with the management. They want to just be free from the uterus, which could be holding the recipe of malignancy.
Yes, exactly.
Yeah.
So as you said, CIN is like connected also to HPV, human papilloma virus, and many times that the result when they take biopsy from the cervix, it come like CIN1. Cervical intraepithelial neoplasia. It's very common. One is very common, and the good about one, it can regress spontaneously most of the time. Of the time, So then it's different than 2 and 3. Okay, they are different, but one, which is the most common, can be treated. And I feel offering hysterectomy for CIN is one of the very
drastic.
Yes, we mentioned some of the cases that we say hysterectomy, removal of uterus, is drastic for this patient. One of them is this CIN1, and women, they think that they have cancer in their cervix and it's better to remove it. No, it's not a cancer, and you can do excision of that part, and many times nothing else, because if you are healthy, your immune system will be able to clear it, but you need a follow-up. Like every 6 months, you do HPV with pap smear and you follow. So this is really, even to that lady, when she asked me about this, I said, look, if you remove your uterus, you will not have a definite treatment, because there are also risks, you remove an organ, so you have a risk. And if you have the reason for this CIN is still there, like you are exposing to HPV, you are having multiple partners, you are not using barrier contraception, so you will still have your risk. It will go to your vagina, as you said. So it's not like they think this is the problem. I remove it.
And actually, their complementary therapies are there also, like some meds are available, some gels
to improve
and some
the immunity.
oral, the immune system to help you throw off this HPV. So for women, it's really, really important to keep uterus, and telling them with the air of authority that you need uterus removal, and not giving them option in this era in 2024. It's too much. And these days we go for informed choice. An informed choice is putting everything on the table and explaining everything to the patient and letting them decide
This suits me.
what suits her
Yeah.
according to her
Not the doctor.
circumstances. Exactly, because it's her life and she need to have the choice what she want.
Yeah.
Maybe she's the one who want to be compliant and follow up, because everybody has a different personality also.
I just want Bushra to say that in case that the woman went for hysterectomy, it's really essential that she should ask about her ovaries, because the trend whenever they go for hysterectomy, if she is 42, sometimes I saw a woman at 40, they remove the ovary. And for us a surgeon, because I want to answer this, is really always irritating me in the clinic. For us a surgeon to remove the ovary with the uterus is easier, is much easier. Especially if you have bulky ovaries, if you have adhesions, it's easier just to remove the uterus with the ovary. Very easy for me. It takes me maybe another 15 or 20 minutes to separate and do, let's say, hysterectomy alone. But you as a woman, if you decided that hysterectomy, okay, I'm convinced I'm going to go, you ask. It's important to ask about your ovaries. Ovaries are essential. There is no discussion that ovaries should be removed. It should be kept. I will not say in 90% of the cases, I will say 100, because if you say 90 people, they will elect to 10%.
10%.
No, in 1%, in 100%, they should be kept. Because if you remove the uterus for that disease, the ovaries should be kept. Of course, we don't talk about the ages that they are above 60 or maybe post-menopause when the period is stopped. It's okay.
When I told you the title of our podcast, think twice before removing the uterus, and then you wrote there, think 4 times when removing the ovaries. I love that one. Actually.
Because it's so much for me. Patients sometimes they come and they are, as you say, they are powerful, they are educated, they know what they want, but the ovaries removed, She said they did not tell me that they will remove the ovaries with the uterus. And then
it should be their choice.
Then it's a disaster after that.
Exactly. And suddenly being like menopause, natural menopause is a gradual thing. They know it's happening, slowly coming, going, ovarian function, but suddenly ovary, hormones, everything gone.
Stop.
They become real empty and they don't know what's happening.
It's like a mess. And you said nice thing, because sometimes I saw patients that they are 45 and then they remove the uterus with the ovaries, and then they will tell her, because you are approaching the menopause. As you say, there is difference. When you approach the menopause, your body passes through gradual, natural decrease in the hormone. So your body will get used. And this sometimes takes 2 to 3 years. Imagine if you stop like the water, you stop at sudden, and look how your body will react.
Become empty.
Yes.
And it affects everything, their bone health, their cardiac health, their mental health, their symptoms. This is a lot. Their memory, and there's something called menopause. Their physique, everything gets affected. So it's an important decision.
Bushra, do you have or do you face a patient that after you are counseling her about everything, and then she said, I want to remove the uterus, and you are not convinced?
Rare.
What you do?
Very rare. It doesn't happen. People really like conservative management. They don't want to be drastic. Maybe in the places where the healthcare system is not so available, so they might ask us like final definitive endpoint of the treatment, and no way, we are not coming back to the hospital. But here in UAE, what I see, people are ready to come to the hospital. They ask you when leaving, when we have to come back. And sometimes they're totally normal people, completely healthy people, and they are like, when we have to come back. So I like this here, and then you have to tell them your pap smear is updated, or it needs to be done in this much time, or your mammogram, it has to be yearly. So, but I like this thing here that when patients are leaving, even after delivery they are leaving, they ask when we have to come back. So it wasn't very common thing in other places, but here it's really common. They come and they ask when we have to come back. So it feels like people are into the
aware.
health.
It's good. Actually, I have patients, I face patients, because that's why I ask you. I face patients that she will come to you, and let's say that you feel that the hysterectomy is not the first option, but still you give her everything on the table and you explain And then, I hear this sentence, doctor, I'm fed up. I just want to remove it. I want to remove it. I don't want to do any other thing.
Maybe being referral center.
Yes, and that's
you
why
guys get that.
Yeah, and that's why you will check that this patient is like, maybe she's suffering from iron deficiency anemia, which most of the people don't realize it's very important.
Yeah.
Her hemoglobin is okay, but her ferritin, iron store, is 0 since 2 years. I look, ferritin below 5, below 5, below 5, below 5. So this will affect her working, cognitive function, her depression.
And she will relate to the uterus.
Yes, and then she will come to you after this 2 years journey, and then she comes, and I see this really in my clinic. And then what I will tell her, I tell her, okay, no problem. I will put for you a date for the operation. I have busy schedule. Maybe it will be in 2 months. But during this 2 months, let's work on your health.
That's amazing.
I give her iron, IV, and then I give her medication, sometimes simple medication to decrease the period. For example, I'm talking. And then, I see her in 6 weeks, When she's coming, she's totally different. Wow. Then she will say, doctor, okay, maybe if we delay the surgery. And I said, okay, no problem. You see, because now she is in her well, and she is, she's well. Now she is well, and she is able to think. Decide, and she tastes the normal life or semi-normal life. Like she's not tired, she's not always sleeping, she can't teach the kids, she can't go to work, she can't sleep well. Yeah. So I think
you gave her even, she should be, when she's taking decisions, she should be in her good health to decide correctly.
And should be also assured that I am respecting her decision.
Exactly.
And sometimes I say, what? No, I respect her decision, she understands, I take it, I absorb it, and let her taste the other thing that she doesn't know,
Bidaya, that was so wonderful discussion as always, and whenever we catch up, it's always amazing.
Yes, yeah.
Being women and being on the forum of She's Well. So these discussions should go on. She should be well, being center of the family, and we are hoping all the women out there to seek help when they need. So we have a small ritual of burning this candle for the hope that these discussions should go on.
I burn or light?
You light it.
I will get a surprise then? Or just? Okay.
If you're advised by a doctor to remove your uterus, take second opinion, third opinion, or even fourth opinion. Do your research. Walk a mile in your own shoes before deciding to remove your uterus. Stay healthy.